introduce yourself to the patient and ask them about their name. By the time they open their mouth, they told you their name, whatever. So my patient is talking full sentence, so he has a patent airway. This is the first steps is finished. And then even you can say, before you start approach the patient, I will make sure I have done all the universal precautions and wearing mask and everything, because even this is COVID time, so you need to mention this point. And then introduce yourself to the patient nicely. If he's comatose, he's not talking to you, he's talking to you, you need to talk to them up to the end of the station. And you have to be nice. Even if the patient unconscious, don't forget, take permission always and explain always. Assume that they can hear you. Because English people believe comatose people can hear. Okay, so like we normally, ideally, you have to open the mouth and look inside the mouth, see if there is any objects, and also we will listen for striders or snoring or gurgling, anything showing that there is airway compromise. If you can see visible body, you can remove it by hand if it can be removed, but don't try to push anything inside, it will make things worse. But if it can be easily removed manually, or you can do suction without problem, you can see the things that, like there is secretion, you can see them, you can do suction, but no, otherwise don't do it, because you will make things worse. And if the patient talking to you, and this is most Simman stations we have in the exam, I would say 99%. هون شغالة حصة برجع لك. So if like 99% of Simman, they talking, so they make our life very easy. We don't need to do head thrust, chin lift, and nasopharyngeal or pharyngeal airway. But assumingly, you will never know them, they can bring things all of a sudden to make few changes. If the patient is unconscious, we really have to do, after you looking at the mouth and remove any obstructions, you need to do head tilt, chin lift at least, so and exclude trauma. So you will say, if the patient not talking to you, so you say, from the patient note, I will exclude that the patient, I will make sure the patient doesn't have any history of trauma, and then I will do head tilt, chin lift, because you can't do it if the patient has, or you can ask the examiner, is there any history of trauma we are aware of or not? So he may reply back to you. In the Simman, the examiner very close to you. This is the only station the examiner very annoying, because he's just, the room is very tight and the examiner sitting there looking at you and listening to every single word you're saying. So you need to explain yourself aloud, explain every steps and showing what you're doing and why. So I would say, like if the patient unconscious, so I will say, are we aware of any history of trauma to this patient? He will say no. So now I can do chin lift, head tilt, chin lift, and you will not get to the point of oropharyngeal or nasopharyngeal. Hopefully it never happened, but if it happened, if the patient fully unconscious, you can do oropharyngeal. If he's semi-unconscious, you can do nasopharyngeal, because the patient will not tolerate the oropharyngeal. Nasopharyngeal, like nasogastric tube, is much tolerated in terms of semi-unconscious patient, he can tolerate it, okay? But just know it to your knowledge, but hopefully the exam will be our normal Simman who's talking to you. So he has patent airway. We don't need to worry about head tilt, chin lift, nasopharyngeal, oropharyngeal is all being omitted for you. And you need, the next step, you need to comment on the oxygen saturations. So look at the monitor, say the patient's oxygen saturation is, for example, 88. So now I'm going to give my patient oxygen, syringe raising mask, high flow oxygen, 15 liters per minute, and take permission from the patient before you put the mask. So your Mr. whatever Smith, your oxygen is very low. Is it okay to give you oxygen through this face mask? You will say, okay, doctors, put it for him and say, thank you so much. Whatever, be nice. Don't forget, Simman is very distressing, so don't forget your IBS mark. The thing that made me pass my Simman station is the IBS, because I consumed lots of time in nonsense. I was trying to give the patient asthma medications through the nebulizer, and there is no nebulizer, and the examiner asked me, go and bring it and put the medication. Because I asked him, I shouldn't have asked him. I asked him, can I give the patient this salbutamol? So like, do I need to give him the salbutamol or just say assumingly? So everyone in the exam, even in my exam, they just said, I'm going to give my patient salbutamol through this nebulizer. You don't need to give it, you don't need to put it in the nebulizer. So this is my mistake. So I consumed time there, but still I passed the exam because of my IBS. I was very kind to the patients throughout, saying sorry, saying thank you so much for bearing with me. You are in a safe hand. I'm here for you, whatever, just reassurance. Don't forget the IBS mark. It can make you pass all blood to if you not forget it, because they want kind doctors. They know you as a junior doctors, you will be with seniors doctors, and you don't need that much medical knowledge to start your job here. But you need lots of communication skills, very good English, because you will be in the face. Always you will be explaining this to the patient and talking to the patient all the time. So the senior just they will give you advice regarding the management, but you will be the person who do the talking. That's why your talking matters a lot. Put this in mind. Don't forget it. Don't rush to finish, show off your medical knowledge. Try to show off your communication skills, and don't forget this. And this is why I'm doing all this pillar to focus in this area. I keep repeat, and still you don't give me that much. In our country, we don't have it, but in this country, it matters a lot. It's not just matter for the examiners, and they teach them in the university. You know, I take part in this teaching, but it's also in the real life. The patient will love you the most if you have good clinical communication skills, if you show good listening to them, and you stop there talking to them and address their concern and find out what worries them and address their concern. They will like you a lot more as a consultant. And this is what happened to me when I work here, because I really just speak to the patient and see what's going on in their head and what really worries them, and I just address their concern from their own point of view. So this is point never sometimes I don't find the right. I think this illness made my memory so. Anyway, you understand me, okay? So never underestimate this area, please, for me, because I did this course for you, and it cost me a fortune of money. Even the doctors who did their exam already, I refunded 50 for two of them, and I had to stop 1 month, as you know, just to teach you this course. So please, in the exam, I will be very upset if you didn't include your IBS. Do as much as you can, and if you didn't pass, come and talk to me. I will refund you fully. But you have to include as much as you can. It will make you pass easily. You know the station, you don't know it, you mess it around. Trust me, just show them you good doctors, you kind doctors, make the patient happy. When you are unhappy, the patient, the role players, they will raise their fingers up like you are good for the examiner to give you higher mark even in your communication skills, because the patient point of view matters a lot. So make them happy, listen to them and smile to them and just make them happy. Don't the patient doesn't care about medical knowledge, so make them happy. Don't rush and panic with the time, and I have to cover this and cover this safety netting. I didn't do safety netting in all station. I didn't do safety netting in all my beloved 2 station. I passed most of them, like I failed 2, I guess. So don't worry, just listen to the patient, stop with them, talk to them, smile with them, address their concern, ask logical questions, and go with the flow. Don't show that you are a robotic person, okay? Okay, so the B, if the patient breathing poor or has a respiratory rate less than 8, we know ventilate, so we need to call cardiac arrest team or crash team, whatever. So, but also most of the station, as I said, the patient is talking and the respiratory rate will be high, 25 or so. So still our management is just non-rebreathing mask, 50 liter per minute, high flow oxygen. This is all we need. We already did it by the end of the A. You can do it here in the B as well, but anyway, it's a very important point here. So we have oxygen saturations, we have respiratory rate, we have this non-rebreathing mask. This is the things we need to remember. We need to mention that about the patient has patent airway, and we are not listening any kind of sound that indicating any airway compromise. Or I can say I cannot appreciate any snoring or gurgling coming from the patient mouth. You can say it loudly. And we will comment that on the oxygen saturation, respiratory rate, and we'll give the patient high flow oxygen, 50 liter per minute on non-rebreathing mask. We will get it from the table, we put it in the patient face, and we will take permission from the patient. And we need to put it nicely and don't lean on the dummy as a dummy. Just always remember this is the patient and put it nicely and tightly around the face. Because in my exam, it didn't fit it well. So the patient is still showing kind of distress. So I realized that I didn't put it well. So I apologize and I fix it properly in the patient face around the nose and mouth. Yeah. Okay. So this is the two the really most important things in the A and B. And in the C, we have by inspections, we look for bular or cyanosis or any distended neck vein. But even if you didn't mention, no big problem. But the really most important things to remember in the C, we have just start from the hand, from the tip of the hand, capillary refill times, okay. It has to be 2 seconds or less. And you can touch the hand. They are not cold or moist, whatever. You can comment on the temperature of the hand if you want to, but it's not a must. And we have going up, we have the pulse. Okay, you need to comment on the pulse. Look at the monitors. You will find it in the monitor. You don't need to do it, but you just look at the monitors for the pulse. You will comment on the numbers. If it is normal, that's fine, absolutely. But if it is, for example, say tachycardia, we need to see if it is regular or not. And we can also speak about ECG at this point if there is problem with the pulse. But if there is no problem, that's fine. But if there is problem, we can mention about ECG in the C. And in the hand itself, we have the cannula. We don't forget about the cannula, but maybe before the cannula, we can just speak about blood pressure. So we have pulse, blood pressure, and then cannula. The cannula, we will do two.
Doctor, one thing I want to ask. Sorry to interrupt.
No problem. Ask anytime. No problem. Yeah.
Okay. The thing is, the monitor doesn't show blood pressure. So do I need to measure the blood pressure, or do I need to?
No, it will show. It will show. You don't need to measure, and there is no any blood pressure monitors in the room, but it will show. It's written in the monitors. There is
written in the monitors. Okay,
yeah, it's written clearly and big numbers with different colors to make you easily see all the numbers. So saturation in different color and pulse in different color. All of them, they have line with them, draw to them like the ECG line, and the number written there clearly for you. Very big numbers. You can't miss.
Oh, okay. Thank you.
Yeah. So you will comment on the blood pressure. If the blood pressure less than 90, so you need to, the ABCD approach is to fix whatever problem you find, to fix it immediately, because they believe that A kill before B and B kill before C and C before D and so on. So whenever you find any problem, you have to fix it straight away. So, and I forgot in the B, we do respiratory examination fully in the B. So we'll do chest by inspection, and you can do percussion or auscultation to the chest. And if you find anything, for example, wheeze, give salbutamol straight away. So if you find any problem, just fix it straight away. And in the C, as I said, we will comment on the pulse, blood pressure, and we will cannula to take routine blood investigation, full blood count, UNE, liver function test, coagulation screen, and group and safe if the patient has suspected bleeding. But otherwise, we don't do it routinely. And we do troponin if the patient has chest pain. But do it as appropriate, yeah, the investigations. You have to mention about investigation at this point before you give the fluid. So if the patient blood pressure less than 90, so we'll give challenge fluid. You can give just 500 ml of normal saline and check for a response. If it improved, or if it's not improved, you can give another 500. And you, if it still has hypovolemia, it could be hypovolemic shock, it could be cardiac problem, you will do ECG, it could be hemorrhage, internal hemorrhage, so you need to do abdominal examination as well to see the source of this.
1 minute, doctor. What is the AVPU? I forgot.
Yeah, so if the patient alert, responding to voice, responding to pain, or unresponsive.
Okay, thank you.
Yeah, alert, responding to voice, responding to pain, or unresponsive. Okay, so in the D, we say AVBU, so we see if the patient alert or responding to voice, responding to pain, or unresponsive. We just do it instead of Glasgow Coma Scale because it's faster, like just giving you a general view about the patient cognitive levels, but it's not as accurate as Glasgow Coma Scale, but we don't do Glasgow Coma Scale in Lab 2. There is no time for that and no one can do it right. Check finger prick for glucose. So in the disability hypoglycemia can do cognitive problem as well. So we'll do blood glucose. And if the blood glucose under 4, we will give IV glucose, as you know, 50 ml of, not 50%. We will give just 10%. We will start with the low concentration. If the patient didn't improve, we can go to 20%, but never 50%. They cancel it. All right. Okay, where is my sharing? Okay. All right. So we said the D, and in the D as well, if still up to this point you didn't know what's the problem, you can do toxicology screen, especially if the patient young, like they will be drug overdose or something like this. But we will check the pupil size and reaction to light. So in the D, don't forget this. It's really important to do pupil size and reaction to light. And we can do neurological examination if the patient has cognitive impairment, but otherwise we don't do it routinely. And in the E, we have the temperature and look over body, including groin. So we look for any injury, any drains, whatever's. E like everything else. So it will be like if there is drain, any catheters, draining urine, will comment on everything. Okay, that's it. So this is the ABCD approach. Is extremely important to remember. And then we can discuss station after the other. Like, for example, hypoglycemia patient. I chose this station because this is the station coming too much nowadays. Hypoglycemia, and the other one I put as well, atrial fibrillation with heart failure. So this station, I guess I went back through the to the exams, recent exams. I found just they bring either this or this, hypoglycemia or heart failure with atrial fibrillations. But also asthma in the past, they used to bring it all the times, asthma stations. So, and they also brought we discussed it before in the past, this is postpartum hemorrhage. One station the patient has a uterus, the other station the patient doesn't have a uterus. So, but all of them, when you know your ABCD approach, this is like 50% of your mark, ABCD approach. Then you have to, if the patient conscious, you can take just tiny bit of data before you start your ABCD approach, or after you give oxygen. The patient has patent airway, I will give oxygen if the oxygen saturation less than 94. But otherwise, if the patient fine, you can forget even about the oxygen. But if the patient has confused or oxygen saturation low, so they will always bring it low for you. They want you to put this oxygen. They're just checking you out. But assuming the patient fine, so you don't need to give the oxygen, the patient oxygen, but you will take little bit of history. So in the Simman station, never ever take lengthy history, even if the patient fine. Take a history that makes you what the problem is. That's it. So if the patient telling you, the doctors, from the task outside of hypoglycemia, they tell you the patient has diabetes, known to have diabetes, and being brought by the ambulance confused, for example. You'll find the patient talking when you go inside the station, but if he's not talking, it's still the same approach. So still, as I said, we will do ABCD approach to the end, and we will do the glucose in the D. But if you know the patient, or you suspecting the patient has hypoglycemia, you don't need to do it just much. Like, for example, I will, in the respirator, I will just do quick auscultations and go quickly, like it will take 1 minute to reach to the D and check the bedside blood glucose and give the patient the glucose. And normally the patient, because he's conscious now, he would have been given treatment at the ambulance anyway. So you need to continue, take it from there and continue the next step. So hypoglycemia. But after the station finish, like ABCD approach, it takes around maximum 4 minutes. You can do it faster in 3 minutes. So after you finish up to the D, so now the patient is stable, you can take your history. So in hypoglycemia, we can ask about diabetes problem in details. When were you diagnosed, what are you taking for it, and how frequent, and are you regular with your medication? Is your diabetes controlled? When was the last time you take your insulin? Details history to show you how he gets this hypoglycemia. So okay, so Riajan, we were saying yeah, we were saying all Simman station ABCD approach is 50% of your mark. It takes up to 3 minutes. After that, after you stabilize the patient, you need to take history, short history, to tell you about the problem in details. So as I said, in the initial minute when you introduce yourself to the patient, if the patient talking to you, you can ask brief history, like 1 sentence, giving you just general idea what the problem is, what brought you to the hospital, whatever, but don't go into details. Even like in the asthma station, I was asking the patient and he telling me, my asthma is killing me, doctors, my asthma, like, stop asking me. So he made it clear, no history at this time. So we will do just quick questions after introducing yourself. How can I help you, or what brought you to the hospital? Just to give you general idea, but don't take it too much. Do your ABCD to the end. and then it takes 3 minutes. After the D, the patient is stabilized now. You can take details history, like for example, asthma station. You already give him the salbutamol in the B. You find the wheeze, so you confirm the asthma. You give him the salbutamol and all the treatment he needs, whatever. In my station, after the salbutamol, he completely become fine. But if they didn't become fine, you need to give ibradrobium bromide, and we will give steroid routinely, or prednisolone like tablets for all asthma patients. But after the D, you need to take details history about what caused this problem, and what, like, you need to give general advice about it. For example, we have the hypoglycemia. You need to ask in details about his diabetes history. When were you diagnosed with this diabetes, and how has it been managed? And for example, how frequent you take this, whatever, and insulin, or he taking hypoglycemic treatments. We will ask in details. So don't forget to ask details history about the problem itself, to give general advice about it. And hypoglycemia symptoms itself, like what symptoms you experienced before you brought to the hospital, and are you aware about hypoglycemia symptoms and how to deal with them. Make it start with the question first. If he doesn't know, straight away give him advice regarding the symptoms and how to deal with it, and about driving. And alcohol can worsen hypoglycemia. You can ask in the history about alcohol and give general advice about it. And if he has any other, so you will ask your full history, past medical history. Has you been diagnosed with any other medical conditions? So some endocrinology problem can cause hypoglycemia as well, but it's not necessarily, because the patient made it clear for you. I took extra insulin. I took my insulin, but I didn't eat. So he will tell you early on in the history. You will find out the reason about hypoglycemia. But you still ask past medical history quickly, and then give your further plan of management. You treated the hypoglycemia. So hypoglycemia treatment, it depends on the level of consciousness. So if the patient is conscious, we can give oral fast-acting carbohydrate. So they have ready oral preparations. They have like Lucozade, sugar lumps, dextrosol. So this is like in the hospital you will find them. If the patient is conscious and still his blood glucose less than 4. So glucagon normally it will be given by the ambulance. So you can ask him about this glucagon. If you've been given any injection in your side or not, because they normally give it subcutaneous or intramuscular in the side. So glucagon, ambulance crew, and when venous access is difficult, glucagon is not suitable for treatment of hypoglycemia due to sulfonylurea drugs. If he's taking sulfonylurea drugs, or he has liver failure or chronic alcoholism, even it doesn't work, glucagon. So we don't need to mention about it that much. So we'll give oral fast acting. But if he's not responding to the oral fast acting, if he's not responding, or he's not conscious, he's still confused or not conscious, we can give just IV straight away. We don't give oral in this case. We give IV glucose 10%. As I said, we always start with the low concentrations, 10%, 50 ml IV. We can repeat in 1 to 2 minutes until the patient is fully conscious. So just remember this. If the patient not conscious, we can give glucose 10%, solution 50 ml IV. Repeat it every 2 minutes until the patient is fully conscious.
Doctor, would you mind if I say you something?
Yeah.
Sorry about that.
No, don't
no, actually, doctor, I booked mock with the doctor, and he suddenly texted me he want to start from 8 p.m. today. He was busy. He didn't give me any schedule. So
Oh, right.
he told me if I'm free at 8 p.m. So can I just go and give that mock? Because
Yeah, of course, of course.
I have no time in few days. I'm really sorry, doctor. It's really.
Don't worry, my dear.
Would you
Don't
mind,
worry.
doctor, please?
No,
I'm really sorry.
Anything can make you pass, it will make me happy. My aim is to make you pass, okay? So whenever anything can help you, please go ahead for it. I'm more than happy. It makes me happy as well as far as you are in the right track. So you don't need to worry. We can, as I said, we'll do another session as well. We can discuss Simman again, continue with it. Yeah.
Okay, doctor. Thank you. Thanks a lot, doctor. I'm really sorry again.
No problem. You don't need to be sorry.
Okay. Thank you, doctor.
Okay, welcome. Bye-bye. Okay, so Ray, if the patient, we said conscious, we can give fast-acting oral carbohydrate, okay? If the patient unconscious, we will give glucose 10% solution, 50 ml IV, repeat it every 2 minutes until the patient is fully conscious. After the blood sugar is normalized, we can continue with long-acting carbohydrate like meals, biscuit, milk, whatever. So just to maintain the blood sugar. But the two key area, the patient conscious, we will give fast-acting oral carbohydrate. The patient unconscious, we will give IV glucose 10%, 50 ml IV, repeated every 2 minutes until the patient is fully conscious.
And then the other question is,
yeah,
like you said, let's say the patient is conscious and is not below, just maybe slightly above 4. We can give that patient a fast-acting carbohydrate.
long-acting carbohydrate.
Long-acting
Yes.
carbohydrate meal, maybe biscuits or milk.
Yes.
Are these things readily available in a hospital setup?
Sorry?
Are these things like readily available in a hospital setup?
Yes, they are available, absolutely available, because they have kitchen. Like they provide the patient with 3 meals a day, so there will be meals available. And especially the meal consists, there will be endless boxes of milk and biscuits and these things.
Okay.
Absolutely available, yeah. And if the patient due meal, like for example, says lunchtime in 10 minutes, you can just make them eat their normal meal.
Mm-hmm.
Yeah. As long-acting carbohydrate.
Okay.
All right. Okay.
I think for hypoglycemia, that will be it. So the key issue is ABCD, then manage all these things.
Yeah, and as I said, we will take in the end of the station, we will take our history with including past medical history, and we will find out why this episode occur and give advice regarding it. Like if he take extra dose, we tell them, please don't take any extra dose without legal medical advice. Yeah, and if has there been a recent change in his drug or like in his medication or anything, he will take you. I take extra dose. As I told, also alcohol can make hypoglycemia worse. We'll ask about alcohol history, give advice regarding alcohol. Be careful about taking alcohol. It can make hypoglycemia worse. And we will make sure the patient is aware about hypoglycemia symptoms and hypoglycemia treatment and driving. Don't drive or take some snacks with you while driving, or please contact. So always regarding the driving, I will just tell to contact DVLA, because DVLA, they will assess the patient. They have their own doctors. So you don't need, even if the patient can't drive, you are not sure, you can tell them, yeah, to contact DVLA. They will give them advice regarding safe driving.
Okay, so in my country, we used also to recommend them to to have a bracelet engraved diabetic or something, just in case they are found collapsed on the road by someone.
Yeah, I think in this country they must have as well. I don't know if this is the case, but if the patient has hypoglycemia, I think it worth giving him this bracelets. Yeah. Yeah, if the diabetes control, I think they don't give. But I think if the patient at risk of hypoglycemia, he need a bracelet because he will be at high very risk of hypoglycemia. And yeah, I think it's good point as well to mention about it. Why not?
Okay.
Yeah, especially when it comes to hypoglycemia. So control diabetes normal, they don't give bracelet. But if the patient has hypoglycemia episode, I think it's very unsafe. So same like any other disease that require bracelets. Yeah. All right. Do you want to practice or continue just discussion?
We can maybe do one.